Good afternoon, everyone. My name is Natalie Foster, and I'm an analyst on the Maternal and Child Health team with the Association of State and Territorial Health Officials, or ASTO. I'm very excited to welcome you all to our third ASTO Connects for the Opioid Use Disorder, Maternal Outcomes, and Neonatal Abstinence Syndrome Initiative, or OMNI Learning Community. Please take a minute to type your state name into the chat box so we can know which teams are on the call today. Today's webinar will discuss Neonatal Abstinence Syndrome, or NAS, which is a topic relevant to the policy goals that many of your teams are working on as part of this learning community. We are thrilled to have the opportunity to hear from three presenters who will offer their expertise on different aspects of the subject of NAS. Before we review the objectives for today's webinar, please take a moment to answer the poll question displayed on your screen. So the objectives for today's webinar are to discuss the CSTE work group on neonatal abstinence syndrome position statement for a standardized case definition of NAS, to explore how West Virginia implemented a real-time surveillance tool to better capture the incidence of NAS, to describe policy and practice related to NAS from a clinical perspective, and to facilitate peer-to-peer and learning and share resources and materials to support state work. We will now turn it over to our first speaker, Lauren Casehagen. Lauren is a senior epidemiologist and CDC assignee to Vermont's Health Department and a member of the Vermont OMNI team. She is also part of CSTE's work group on standardizing the case definition of NAS. You can find Lauren's and the other speakers' full bio in the document attached to the calendar hold. Please type your questions for Lauren into the chat box, and we will answer questions at the end of all presentations. Lauren, the floor is yours.
Thank you. Go ahead and advance the slide. So I want to thank everybody for joining today and for the invitation to speak. What I'm going to talk about is the culmination of about 2 years worth of work, and it represents the concentrated effort of a number of epidemiologists, including those in Vermont, Pennsylvania, West Virginia, Florida, Missouri, Washington, Idaho, New Mexico, and Georgia. So if you'll go to the next slide. I'm not going to talk about the background. I think all of you are well aware of why we're here today and why we actually might need a standardized case definition. So if you'll go to the next slide.
There we go.
So what came to our attention as epidemiologists was that a standardized case definition was needed because we didn't have a clear understanding of how NAS was being diagnosed or how a clinically compatible presentation might be made. We also had no clear understanding of what is documented in the newborn record. The diagnosis codes did not allow us for a clear-cut case definition, and we had some uncertainty about how different states and clinicians were defining NAS. We didn't know if it was based on signs of withdrawal, types of drugs, or exposures. We didn't know timing of exposures, or whether it was a much more complex picture than that. So that led to the formation of an epidemiologic work group at CSTE. If you go to the next slide. This is just a brief timeline of the events that have been going on since about June of 2017, where we first identified the need for a work group, convening of the work group that fall in 2017, conducting a 50-state environmental scan on NAS definitions, data sources, and reporting, the convening of a multi-state NAS leadership group in December of 2018, where we voted as state representatives to draft a position statement for an NAS standardized case definition. In the past 3 months, we have worked diligently to form that case definition, consulted a wide range of experts, and came to consensus on it, and then filed that position statement at the beginning of March. And if you'll go to the next slide. Prior to that, we had conducted an environmental scan, and these are the high-level findings of the scan. Only a handful of states, less than a third, have NAS as a reportable condition. There are a variety of different data sources that are in use, but most states use hospital discharge, Medicaid, or all-payer claims. So it's based on those ICD-10, or in the past, 9 clinical modification codes, which really don't have the specificity that we need for a case definition. If you'll go to the next slide. In determining a case definition, CSTE requires that we identify surveillance goals and challenges. So ideally, surveillance would allow us to estimate an incidence of NAS, track trends, evaluate effectiveness of some neonatal interventions, monitor the impact of in utero exposure on long-term health and development of infants, identify women with a chronic opioid use disorder, and help link those women to treatment, plan for public health and clinical resources for families, and lastly, connect families with health and social services. Next slide. The key surveillance challenges include developing a case definition that all states can use, given each state's needs and resources, advancing definition amidst a lack of clinical consensus, advancing definitions that use current ICD-10 CM codes, addressing NAS in the context of substance use exposure in pregnancy, and then desire to not contribute to further stigmatization of women. Next slide. This is the definition of NAS that we use in our case definition. You can see that it really focuses on opioids, benzodiazepines, and barbiturates. And then these are the withdrawal signs that we're considering. If you'll go to the next slide. The requirements for the case definition include there must be withdrawal signs in the neonate. There must have been in utero exposure to opioids, benzodiazepines, or barbiturates. And then we're considering the severity of condition. For example, requiring a pharmaceutical or an alternative treatment, such as eat, sleep, and console. Next slide. So CSTE, our work group took a 2-tiered approach to accommodate the state needs and resources. Tier 1 definitions are case reports to public health legal authorities. They are based on the clinical records, and the reporting is done by providers, or in some cases, if the state chooses, laboratories. Tier 2 definitions are case reports that are based on administrative claims-based data, so Medicaid, all-payer claims, or hospital discharge data. They use these diagnostic codes, and the reports are made by providers and facilities. Next slide. So here we go into the various tiers and types of case definitions. So a Tier 1 confirmed case definition is a neonate less than 28 days of age, hospitalized or admitted to a pediatric recovery center. The reporter identification is in absence of another known cause or diagnosis. So we have a diagnosis of NAS, a chief complaint of NAS, or a clinically compatible presentation of NAS where there are 3 or more signs of withdrawal with confirmatory neonatal laboratory evidence. The laboratory evidence is any positive test. We can live with ambiguity right now or low specificity, but the focus is on a neonatal test. And the withdrawal time is within a week of exposure. Other things that I might want to highlight, we're going to defer to the clinician's judgment about the chief complaint or the diagnosis of NAS. And then the 3+ signs are based on state experience. So what we're trying to do is increase severity and specificity. We've heard about withdrawal from non-opioid drugs, but our neonatologist experts suggested and recommended that we focus on the drugs that are known to cause signs of withdrawal as opposed to a toxic effect, something that might attenuate or exacerbate signs of withdrawal, but aren't in and of themselves drugs that would cause withdrawal. If you'll go to the next slide. A probable case is in a neonate less than 28 days of age, hospitalized or admitted to a pediatric recovery center. The report or identification is in absence of another known cause or diagnosis. So it's a diagnosis of NAS, a chief complaint of NAS, or a clinically compatible presentation of 3 or more signs of withdrawal, and maternal history of chronic opioid or benzodiazepine or barbiturate use with confirmatory maternal laboratory evidence. The maternal evidence, again, where it's preferred, and that would lead us to our probable case. Our next slide is the suspect case, and it's where you don't have to have the lab results if you have a maternal history of chronic drug use of a non-opioid, non-benzodiazepine, or non-barbiturate drug. So you can see that the first 2 cases really do depend on an exposure to opioids, benzodiazepines, or barbiturates. Here for the suspect case, we're relying on that there may have been exposure to an opioid, benzodiazepine, or barbiturate, but we don't have true evidence of that. We don't have a maternal history or a confirmatory lab result of an opioid, benzodiazepine, or barbiturate use, but we have a non-drug in those classes. But we are asking that there's some sort of history or lab. And the next slide. Another way we can have a suspect case is if we have a neonate who's been hospitalized or admitted to a pediatric recovery center in absence of another known cause or diagnosis, where you have a clinical presentation of less than 3 signs of neonatal withdrawal, and maternal history or confirmatory lab results of chronic opioid, benzodiazepine, or barbiturate use. And next slide. The Tier 2 cases for confirmed are those neonates whose healthcare record contains any diagnosis of a neonatal drug withdrawal symptoms within the birth hospitalization or hospitalization before 28 years of age. The only code we have available to us presently to distinguish this is P96.1. It's not very specific, so it includes all drugs of addiction, rather than specifying something like opioids, benzodiazepines, or barbiturates. So right now, some cases that would be identified as suspect under Tier 1 could become confirmed cases under Tier 2. And this is solely because we don't have specificity of our ICD codes to capture the type of exposure that we need in order to make that distinction. So if you go to the next slide, you can see that the next definition is suspect. There is no Tier 2 probable case, again, because we don't have the specificity of codes. So a suspect case is a neonate whose healthcare record contains any diagnosis noting maternal use of opiates, sedative hypnotics, or anxiolytics affecting the fetus within the birth hospitalization or hospitalization that's similar to a clinic admission before 28 days of age. The ICD-10 codes here are exposure to opiates, barbiturates through the sedative hypnotics, anxiolytics, which are benzodiazepines or even the antidepressants. Previously, we used P04.49, and that was a neonate whose healthcare record contained any diagnosis noting maternal use of unspecified or other drugs of addiction, not including cocaine or hallucinogens or narcotics affecting the fetus within a birth hospitalization or subsequent hospitalization. Next slide. Part of our position statement includes an appendix that will help us interpret data and the use of the standardized case definition in various circumstances, and promotes the use of better diagnosis codes and the benefits of maternal infant record linkages, as well as potential biases that we might incur. There are a number of concerns that we have going forward with the standardized case definition, even though we feel it's the right approach. Next slide. One has to do with the specificity of the ICD-10 codes. So we need more specific codes. We need we know that some suspect cases identified under Tier 1 will become confirmed cases until Tier 2, until we have specificity. Next slide. We also have concerns about laboratory reporting of drug exposures. Right now, supportive information only, but any level of confirmed positive result is acceptable. We have concerns about whether it is sufficient for confirmation to use immunoassays. We know there could be possible misclassification of infants based on cross-reactivity. And we hope that the tests capture, we know that tests can capture varying timeframes of exposure. We hope that positive results up to 4 weeks prior to delivery will be sufficient, but maybe not all tests have that ability to do that. Next slide. Polysubstance exposure. We feel it's important to not only capture opioids, but also benzodiazepines, barbiturates, alcohol, nicotine, other medications, methamphetamines, amphetamines, cannabinoids, marijuana use, all of those. So we're recommending that those types of exposures be captured on the case report form. And it's up to states to determine what that case report form will look like. Next slide. It's also helpful for our public health goals to capture all in utero exposures and to determine whether there were no mild, moderate, or severe withdrawal signs in the neonate. So we hope going forward that we have a statement framework that will support the states in moving toward that approach and to allow for clinical consensus to be built. So in summary, we've got a two-tiered case definition. It's not perfect, but we hope it moves our field forward and promotes more consistent diagnostic and coding practices while the pediatric clinicians develop consensus. We also hope that with improved clinical consensus and coding over time, that our tiers can be combined so that they're a lot less confusing and less numerous, and that we have better guidance for using the clinical and administrative codes and records. Thank you, and if there are time for questions, that would be great. At the end of this presentation, there are also some next steps that you'll see if you are able to attend the CSTE conference in June, where we vote on the position statement.
Wonderful. Thank you so much, Lauren, for discussing the proposed standardization of our NIS case definition. All slides are in the calendar hold, so you can go back and look at the next steps that Lauren referenced, and we'll be answering all questions at the end of presentations. So continue to chat your questions in. And we're now thrilled to introduce Dr. Stephen Patrick. Dr. Patrick is the director at the Center for Child Health Policy and an assistant professor of pediatrics and health policy in the Division of Neonatology at Vanderbilt University School of Medicine. Dr. Patrick, take it away.
Thanks so much. It's an honor to be here with you all today. And I think in many parts, a lot of the talk I'm going to give is preaching a little bit to the choir, knowing some of you who are on the call. So I'm excited to talk to you guys and hear a little bit more about some of the work that's happening in the States. You can go to the next slide. So just very briefly, we're going to talk about substance use in pregnancy, kind of in the context of my own personal experience clinically. Talk about neonatal abstinence syndrome. I'm going to talk a little bit about our care model because I think it just informs a lot of the things that we've done recently and perhaps the way that we're responding to policy and public health changes around us, and close with some recent policy changes. Our group here really aims to do research that evaluates the effect that the opioid crisis has had on both pregnant women and infants, and then to try to apply those that work to the clinical care that we deliver at Vanderbilt. Next slide. So this was my introduction to the opioid crisis. It wasn't so long ago that I was in training, and we just started seeing more infants having opioid withdrawal. And as a neonatologist, those infants are just different. We are used to caring for very small infants or infants with complex birth defects, but these infants are just different. They need medical care, but they generally aren't critically ill. Most of the infants, if you walk around the NICU where I'm sitting now, most of the infants I'm caring for are very sick, on ventilators and things like that. These infants are big and they cry and they're robust, and so they tend to stand out. It was really this observation in the NICU that made us sort of step back and wonder what was happening to our families outside the NICU. What was the broader context in terms of the opioid crisis? And that really began our journey into trying to understand this problem a bit more deeply. Next slide. So we know that substance use in pregnancy is not that uncommon. And we are focusing a lot on the opioid crisis now, but it is worth stepping back as we think about the systems that you all are designing and that we're thinking through. At some point the opioid crisis will begin to plateau and subside. But we're already seeing reports of methamphetamines in some communities. Cocaine is also making a comeback. And so how can we begin to build systems of care that are responsive even when the medication or the substance changes? Overall, about 7.5% of pregnant women that are age 18 to 25 use some illicit substances, about 5% overall. Notably, that's much less than the general population where it's about 12.5%. And that's because during pregnancy, women make changes. They cut down on the substances they're using, they seek care, and so it's important that we have treatment access available to them. Being here in Tennessee, and it's true in probably many of your states, we have really high rates of smoking as well. These are national numbers on this slide. About 14% of pregnant women still smoke cigarettes, and 1 in 10 pregnant women still use alcohol. And it's really important as we think through public health approaches to substance use. Our goal should be healthy moms and healthy babies, and really should be comprehensive. It's more common than not that there's polysubstance use. We've done some work looking at alcohol use, for example, among women who misuse opioids, and it's pretty high. It's about 50%. So we have to keep that in mind. And then next, SAMHSA, the Substance Abuse and Mental Health Administration, estimates there are around 440,000 infants each year exposed to illicit drugs or alcohol, but we only detect about 5% at the time of birth. And that's because not every substance has a withdrawal syndrome. And so again, this is why having a holistic approach from a public health perspective, engaging moms throughout the continuum of care is really important, not just focusing on the birth hospitalization. Next slide. Well, again, this is a bit of the choir that I'm talking to, and I know that, but it's always worthwhile, even for a neonatologist like me, to talk about why we do buprenorphine and methadone. And those are the 2 medications that are recommended for treatment in pregnancy. You can click on the next. We know that when pregnant women use methadone or buprenorphine, or they're prescribed it in pregnancy, it decreases the risk of overdose death, relapse, hepatitis C, and HIV. Now, you can imagine that if a pregnant woman is using heroin, for example, she's going through rapid cycles of intoxication and withdrawal, intoxication and withdrawal. That's stressful for her, and it's also stressful on the developing fetus, making it more likely that moms are going to go to preterm birth. Thank you. Thanks for reading my mind. We know also that when moms use buprenorphine or methadone, infants are more likely to go to term and have higher birth weights, though this does come with some risk of withdrawal. One of the things I always talk about when I'm talking to the community or policymakers, what we're sort of trading here is the risk of having a 25-week infant in our ICU, which we know has a slew of lifelong complications potentially, for a term infant who may have drug withdrawal. 25-weekers don't have drug withdrawal. They're just too immature. And so even when we're talking about capturing the scope of the opioid crisis, we oftentimes will miss it if we just focus in on drug withdrawal, because we do have infants. I have infants in my unit right now that are opioid exposed but don't have drug withdrawal for various reasons, including being too immature. Next slide. So even though we know these medications work, opioid agonist therapies, most pregnant women in the US do not get them. Even among women who are admitted to treatment facilities nationwide, less than half receive opioid agonist therapies. We did some work just looking at, surveying all opioid treatment programs in 4 states throughout Appalachia, and a sampling of outpatient buprenorphine providers. We found that only half of providers accepted any insurance at all, and only about half of outpatient providers would take pregnant women. Here you can see Medicaid acceptance and then private insurance acceptance by state, and you can also see a wide variation there as well. Next slide. I stole my thunder. That again, about most opioid treatment programs, most of them take pregnant women, but only about half of outpatient buprenorphine providers. Last time I checked for some states, so my home state of West Virginia, there's only 9 opioid treatment programs last time I checked in that state. So while it's true, opioid treatment programs are more likely to accept pregnant women, there just aren't that many of them. Next slide. So what is neonatal abstinence syndrome? It's a drug withdrawal syndrome that newborns experience after birth. It generally follows an opioid exposure, though if you look in the literature, there are other exposures that are there, including alcohol, benzodiazepines, and barbiturates. And in the current case, we've done some work reviewing cases of neonatal abstinence syndrome that are reporting billing codes. Almost all involve an opioid plus another substance. The literature suggests that around 40 to 80% of heroin and methadone exposed infants develop neonatal abstinence syndrome. About 5% or so from some of our work looking at prescription opioids develop drug withdrawal. Next slide. So thinking about the clinical features of drug withdrawal, it is where the opioid receptors live. So the GI system, commonly what we see for infants who have drug withdrawal is poor feeding, vomiting, and loose stools. This can lead to pretty profound dehydration and poor weight gain, even pretty early. I've had infants lose up to 10% of their body weight within the first 48 hours of life. Common central nervous signs include tremors and hypertonia, so increased muscle tone, tremors, shaking, irritability, decreased sleep, exaggerated reflexes like the Moro, which is the very cute startle reflex that babies do, and then less commonly seizures. And it should be notable that seizures is somewhat controversial as a diagnostic sign because it doesn't happen in other populations that have drug withdrawal, and then some autonomic signs as well. Next slide. So the incidence of neonatal abstinence syndrome, this is from a couple different studies from our group. On the y-axis here is rate of neonatal abstinence syndrome per hospital birth, and the x-axis is year. And this is using hospital billing data, looking at some of the ICD-9 and then 10 codes. From 2000 to 2016, nationwide, the incidence of neonatal abstinence syndrome grew by about 7-fold. We are starting to see a little bit of a decrease there. We'll see if that persists. But around once every 15 minutes in the United States on average, there's an infant born with drug withdrawal. Next slide. We've also done some work trying to look at excess costs, and we do this in part because we spend a lot of money in neonatal ICUs where I sit currently. Imagine if we could use those dollars elsewhere. Imagine if we were able to shift dollars prenatally or towards postnatal, home nurse visitation, other things that we know that work. Perhaps if we did shifted dollars that way, we would be more efficient, we provide better care, and we may actually utilize NICUs less. From 2000 to 2014, from some of our work nationally, Medicaid had an excess of $2 billion that was spent in hospital costs just for neonatal abstinence syndrome, just for the birth hospitalization. This is essentially what it costs to care for neonatal abstinence syndrome after you subtract the normal newborn costs. Next slide. So to treat neonatal abstinence syndrome, our goal is to control withdrawal, minimizing the complications, including seizure. We first begin with non-pharmacologic interventions in controlling the environment, namely allowing mom to room in, promoting breastfeeding when it's appropriate. For severe withdrawal, we use an opioid like morphine, methadone, in some cases buprenorphine, some centers use, slowly decreasing the dose over time. Next slide. You know, we just had a great talk about setting gold standards, setting surveillance definitions. We struggle a lot with the complete lack of standardization and gold standards. The clinical definition was, the current tools that we have were developed in the 1970s. They haven't been validated. They were developed on term infants, primarily heroin exposed. There's no, even though we have these tools that most centers use, the modification of the original Finnegan score is the most common. There's no agreement on the threshold for diagnosis. What does a score of 8 mean versus 10 or 12? No one really agrees. There's no standardized treatment protocol. Surveillance definition that we just discussed is variable. Hospital billing is also a variable. It may represent exposure, may represent severe neonatal abstinence syndrome. Next slide. So I'm going to just talk a little bit about what we're doing at Vanderbilt to try to improve the care that we're delivering. Next slide. You can advance. So the most common model of care that we see in the United States is this. Transfer to tertiary care facility for an infant with neonatal abstinence syndrome, separating mom and baby from each other, and placing the baby in the neonatal ICU. And if you've ever been in a neonatal ICU, you know that oftentimes it's an open bay. You could have a baby on heart-lung bypass or on a ventilator next to a baby having drug withdrawal. And imagine if you were going through drug withdrawal, being in a loud, chaotic environment is not always the best place to be. The treatment is frequently separate from the mother, doesn't include the mother. Breastfeeding commonly not allowed, or at least it's inconsistent. We oftentimes focus on the correct medicine. So that even in our literature, should we give morphine or methadone or buprenorphine as opposed to the correct care process? Burnout is common. We have a lack of trauma-informed care processes throughout. Care is oftentimes not standardized. We have very long lengths of treatment and stay. In some centers, length of stay reaching 100 days in some cases. Next slide. The newer care models are shifting this, making it more inclusive, care more inclusive of mom. So maybe not transferring to a tertiary care facility, keeping the dyad intact, mom and baby together outside of the NICU when possible. Treatments inclusive of the mother, so engaging mom and doing things like scoring and assessment of the infant. Breastfeeding is encouraged and supported. We have national guidelines for when it's safe to breastfeed. Focus on the care process, not just the medications. Engaging the staff in trauma-informed care, standardizing things. And we found greater provider and patient satisfaction as well as reduced length of stay. Next slide. So we created a team that we call Team Hope. It is intentionally multidisciplinary. It includes physicians, nurses, social workers, child life specialists, lactation consultants, and volunteers. Next slide. We have folks on our team that are from our obstetrics, general pediatrics, outpatient pediatrics, as well as the NICU. So we no longer admit infants that have neonatal abstinence syndrome to the neonatal ICU. They stay with the mom first in the newborn nursery. And if they have a prolonged length of stay or if they require morphine for treatment, they go to our general inpatient floor where the mom can room in. We've had nearly 200 infants go through our program in the last 18 months. We diagnosed about 25% with neonatal abstinence syndrome, and you can see how variable this is. So a diagnosis of NAS doesn't always equate to opioid exposure. This is based upon clinician diagnosis of NAS. Only about 19% of opioid-exposed infants received a single dose of morphine. We had about 2 readmissions. Next slide. We were fortunate to get some funding from a local foundation to hire a child life specialist and part of an FTE of a lactation consultant. Most of our moms have seen, or families have been seen by a child life specialist. We're beginning to onboard new volunteers. Nearly 70% of our moms were eligible to breastfeed. 88% of moms who were eligible expressed some breast milk during the hospitalization. 81% of babies were still receiving breast milk at the time of discharge. That's a big shift and a big change. Next slide. And this is really why I think we've had a big shift, and I'll talk about our length of stay here in a second. it has to do with what we do in the newborn nursery. In the neonatal period, we provide a lot of resources and we control that environment right after birth. We engage moms in breastfeeding. We keep moms and babies together. We have a child life specialist help mom interpret what's going on with her infant, supporting the family. So most of our infants are now discharged from newborn nursery, and we observe all opioid-exposed infants for 3 to 7 days per AAP guidelines. Most of the rest are discharged from our pediatric medicine acute floor, which is just our general inpatient ward. Only 2% were discharged from the NICU. Next slide. Our total length of stay, median length of stay, is 5 days, and that's for all comers, all opioid-exposed infants. And for infants who are diagnosed with NAS, it's 13 days. And this is about half of where we were before. Next slide. So some of our work now is focused on improving transitions home, and I think it's important to bring up in this group because it includes connection to a lot of public programs that I think you all think about. Next slide. So one of the things I think that until recently has been missed is thinking about hepatitis C. So some of the work that we've done with our colleagues from Tennessee Department of Health, some of whom I think are on the call today, has just been looking at the national incidence of hepatitis C among pregnant women. And what we've seen over the last 5 years or so is a doubling nationwide of the number of pregnant women with hepatitis C. And in our current state, in Tennessee, it's about 1% of births where I live currently. In my home state of West Virginia, it's about 1 in 50 births in 2014 were exposed to hepatitis C. Next slide. So the problem is, even though vertical transmission is relatively low, it's about 6% overall, 11% if there's co-infection with HIV, we do a pretty poor job of following infants who are exposed. So Wisconsin Department of Health looked recently in an MMWR, and they found that about 34% of infants who were exposed were tested to see if they converted. We're doing some work here in Tennessee of 4,000 hepatitis C exposed infants for about a 10-year period, followed for 2 years to see if they were tested. Only about 22% were tested, and African-American infants were about 60% less likely to be tested, accounting for a slew of other factors than Caucasian infants. Next slide. So what does an optimal discharge look like? So I do believe it begins with beginning in the hospital, birth hospitalization, encouraging breastfeeding when that's appropriate, engaging the family early on. I think sometimes we have these long NICU hospitalizations where we disengage families and we sort of lose them at the beginning. Assessing the family needs, including at the very beginning, and engaging them in follow-up, and assessing other risks, so hepatitis C, mental health needs for mom. It considers the post-discharge needs, like home visitation, engagement in the child welfare system, IDA Part C or early intervention. Perhaps we need more frequent pediatrician visits, as well as better coordination with maternal treatment and maternal follow-up post-discharge. Next slide. So this is where some of our work has focused. How can we make sure we have a good discharge? And we've been thinking a lot about this. And so a good discharge for us is do we have hepatitis C follow-up when it's appropriate, developmental follow-up for infants with neonatal abstinence syndrome, engagement into early intervention services, making a primary care doctor appointment before we leave home. So you can see earlier this summer, we were doing this about 1% of the time, every time. You can keep advancing here. And we went through and sort of audited what we were doing, and even just talking about it got it to be a bit better. We created just a simple checklist that happened in electronic medical record, and that improved us to about 60% where we are now. We still have room for improvement, but I think just focusing on it's important. Next slide. So what about communities? I'm going to go through this a little bit quickly. One of the things we've been thinking about, it's really evident when you encounter families in our NICU, that this isn't just about the substances, it's about what's going on in the community. Many moms have long history of trauma and abuse, and we wanted to understand what was going on in the community. What role did long-term economic downturns have, for example? What role did lack of ability to access mental health care? So you can advance here. You go ahead and advance here. There you go. Keep on going. So we focused in on 8 states where we had data, county level estimates here, the states that we have. And I'm just going to show you the Kentucky, Tennessee, and North Carolina just to focus in. These are, and you can go ahead. These are incidents of neonatal abstinence syndrome by county. The darker the blue, the more intense the incidence of the NAS. And just go ahead and advance here until 2015. So what you can see is a pretty stark increase that many of you know and understand. And so we wanted to understand what was happening in these counties and focusing in on long-term unemployment as a potential association between NAS based upon some other literature. We can talk about this in the Q&A. But next slide. So here's an overlay of counties that have high long-term unemployment, and that's a moving average of unemployment at the county level for 10 years and high rates of NAS. The purple counties are those counties. These are counties that have high unemployment, high rates of NAS. And our analyses looking at accounting for a slew of other things, we find that in remote rural counties in particular, about a 2 percentage point increase in long-term unemployment was associated with a 34% higher rate of neonatal abstinence syndrome. Next slide. You can play with these data on our website, by the way, if you just go to childpolicy.org/NAS. Next, you can keep advancing here. Keep on going. All right, keep going. Great. I'm just going to close here with some policy change and focus in on the things that you guys are dealing with. And I know our own state is dealing with this in terms of their work group. We've seen just an amazing amount of change to the child welfare system over the last 2 years. I'm going to focus on things that happened just in the last year. First is Families First, where we can now use dollars for prevention for prevention and specifically targeting mental health and substance use too. This is a big change that I know many of you are talking through now and how this is being implemented at the state level. The Omnibus Budget Act created some funding last year for plans of safe care. I know many states are working on plans of safe care now. How can we ensure that we keep infants safe? But the language that's written now from the Comprehensive Addiction and Recovery Act is that it needs to be inclusive of moms' needs too. How can we ensure that we connect moms to treatment? The Support Act, I think, made a big push in this direction that provided both funding and greater specificity to states what a plan of safe care should look like. But I know there's still a whole heck of a lot of work to go. This is the specific language of the Support Act. But if you've read the Support Act, there's about 6 or 7 pages directed towards this. Next slide. Plans of safe care, I think, are one of these things that I think can be a vehicle for when we think about change and connecting vulnerable populations to really important public health systems that right now, as we discharge infants out of the ICU, can be completely uncoordinated from our standpoint. So how can this endure? I mean, you look at what's written in the legislation, it specifically calls out the Child Welfare Agency, IDA Part C, MICV, public health and mental health agencies, residential treatment, the judicial system, treatment facilities, Medicaid, and Title V. All important. And I think one of the things I love about thinking about how plans of safe care can look moving forward is beginning to coordinate and beginning to think through how can we make lasting change moving forward through this. Next slide. Just going to call out kind of last year is the American Academy of Pediatrics statement on opioid use, public health response to opioid use in pregnancy that highlights a little bit of things that state and federal governments can do. Next slide. The focus on that is really focused on public health approaches, including improving access to contraception, everything down to enhanced funding of child welfare. Look, concluding, the scope of the current crisis is unprecedented, and we do have barriers that exist. I think, this group is particularly important because it's focusing in on the specific needs of pregnant women and infants, and I think oftentimes that is missed. As we think through this current crisis and we think through substance use overall, it's not just about the drug use, it's also about economic opportunity, social network that I think matters. We can talk more about that. I think the opioid crisis really can be a vehicle to improve maternal child health long-term as we think about how to apply what's going on now moving forward and thinking through life course approaches. Next slide. I think that's it for me. You can go through these. These are just thanks to everyone on the list. This is Team Hope and our funders.
Wonderful. Thank you so much, Dr. Patrick, for that very informative presentation. As a reminder, please continue to chat your questions into the chat box, and we will answer them after Dr. John's presentation. So we're very excited to hear from Dr. John next. He is an associate professor in internal medicine and pediatrics at the West Virginia University School of Medicine. He is also the medical director for the Project Watch, West Virginia's Birth Score program. We'd also like to take a minute to highlight the recent state success story that ASTA developed on the West Virginia Birth Score program. The document is attached in the calendar hold, and so you can learn about additional background on the program and the tool after Dr. John's presentation. Dr. John, take it away.
All right. Well, thank you for inviting me to talk about this. This is one of my elements of pride and joy in my job. And so Project Watch actually kind of does a lot of stuff, and I was asked to give a kind of a high-level core overview of Project Watch. We'll touch a little bit on how it is involved in NAS surveillance, but it actually transcends that, and I think it's important to look at the evolution of the scoring system and then what it's doing today for our state in particular. So you can advance. So this actually all started in the 80s. One of our faculty members here, Dr. David Meyerberg, who is a neonatologist, really wanted to put a dent in reducing post-neonatal mortality rates. And at the time, West Virginia was one of the highest. And so he actually went to England and noticed that they were doing a scoring system that a Dr. Robert Carpenter developed, and which was called the Sheffield score. And so he brought that back with him to West Virginia and created what he coined the term the birth score. And essentially, there were 8 factors of maternal and infant characteristics that contributed to the score. And over the years, it kind of gained a foothold in the state. And then in 1989, it was officially adopted by the Office of Maternal and Child Family Health for statewide implementation. So you can go to the next slide. And that actually, I don't know how clear that comes up on everybody's screen, but this was the actual first birth score that was implemented in the state. And so you can see kind of in the left side on the middle, there are the 8 factors that contribute. So you have maternal age, blood type, second stage labor duration, previous pregnancies, and so on. And so when you added those scores, those weighted values all together, essentially the 15%, the highest 15% of scores were considered a high score. And then it was those infants that we were really trying to focus on as far as getting them appropriate care, since those were the ones that were most likely to die within the first year of life. So you can advance. So as time went by, one of the big landmark years for this was in 1998, where our legislation actually mandated that the birth score, as well as universal newborn hearing screening for all infants born in West Virginia, was passed. And so essentially doing the birth score on every child was now a law. And then in 2000, we added the newborn hearing screening parts to the birth score. And then in 2007, Dr. Mullett, who was the successor to Dr. Meyerberg here at WVU, actually undertook some statistical analysis to try and revise the birth score tool. And I'll show what that looks like here shortly. And then in 2012, we were asked from the OMCFH folks to serve as kind of the launching point for screening for critical congenital heart disease. And then we added that in 2012, and we've been tracking that ever since. And then a year later, we got rid of the paper forms and went to an electronic version of the form. And so essentially now the birth score can be done at the birthing hospitals via 2 mechanisms. The first is via that web page, which leads them to a portal, and where nurses who typically will fill out the birth score, and it's usually done right before an infant is discharged, they can go through the various parts to the birth score. Or we actually have several hospitals where it is actually implemented in their electronic medical record, and so it can actually pull data from the EMR and then transmit it to us electronically. And then a couple years ago, we were asked by our West Virginia Perinatal Partnership, along with the DHHR, the Department of Health and Human Resources, to address NAS surveillance. And as we've seen on the last two presentations, that trying to do surveillance for NAS can be very problematic in several aspects. You could go to the next slide. So one of the great things about the program currently is that we have 20,000 babies that are born in West Virginia every year, and we're able to reach every baby through Project Watch. And I think its longevity has made it very easy to do that, since it's been around about 30 years or so, 35 years or so. And now with the revised version that Dr. Mullet had created, we actually have about 18% of babies that are high score based on the combination of maternal and infant risk factors that are present. So you can go to the next slide. And this is really what the birth score program is meant to do. It's an infant risk screening system that identifies those newborns that are at the greatest risk for poor health outcomes and possibly preventable deaths within the first year of life, and then to link those infants with primary pediatric services and case management for close follow-up during the first year of life. So you can go to the next slide. So when Dr. Mullet revised the system initially, she developed a weighted 7-factor system. So she changed some of the factors, changed some of the weighting, and then also added in an evaluation of the baby's risks for developmental delay. And then as new stuff was added, such as the newborn hearing, critical congenital heart disease screening, neonatal abstinence syndrome surveillance, we also have done surveillance for exclusive breastfeeding at discharge, as well as the incidence of gestational diabetes. It's kind of taken on a big evolution. And so at that time, we kind of decided that it really wasn't just about the birth score anymore. And so that is why we changed the name to Project Watch, which the acronym is spelled out in the intro slide, which you will all have. Next slide. So the 7 factors that were deemed to be relevant as far as predicting infant death within the first year of life are listed there. So you have baby's birth weight, maternal age, sex of the baby, feeding intention, previous pregnancies, mom's educational level, and then whether or not mom smoked during pregnancy. And you can go to the next slide. So this is what the birth score then looked like right after Dr. Mullet had revised it. And so you can see on the left there, the birth score proper, which is those 7 maternal factors going down the left side. And then if you look at the right side, you can see several other things. So you have the newborn oxygen saturation screening, which at the time when we implemented this was just simply pass, fail, not screened, or NICU. And then whether or not the newborn hearing screen, what the results of the newborn screen were. So go ahead and to the next slide. So this slide just shows how the birth score changed more specifically from when Dr. Mullet and Dr. Meyerberg worked on it here. So, you know, looking at developmental risks, which actually, if they meet one of those 3 criteria, they're an automatic high birth score. And those babies that have one of those 3 automatically get a birth to 3 referral here in West Virginia. And then we looked at, of course, gestational age, NICU, newborn hearing, diabetes, BMI, NAS surveillance, and CCHD screening. So you can go to the next slide. So this is what the birth score, if we were to have a paper version of it, which we actually will give to hospitals for them to put the data down and then enter it into either their EMR or the electronic portal that we've created. And so this is where we're at now. So again, on the left, or we were, I should say, on the left was the birth score proper, and then on the right, you can see that we actually expanded the newborn oxygen SAT screening to include each of the oxygen saturation levels and whether or not they passed the screen or not. And then, of course, we still have newborn hearing. And then at the bottom is the more relevant to the group here, is where we started to focus on NAS. And, you know, when we met and tried to talk about a good way to put NAS surveillance on our tool, we knew that, number one, that our tool was a really, really good way to do this because we reach every baby. The thing we had to consider when our committee met and decided to implement this was, you can already see that there's a lot of stuff on the birth score. And so the more we add to the tool, the more likely there is to be errors. And so we had to be very cognizant of what we wanted to put on it. And so when we met, we really decided on really two questions. And so the first question at the bottom there was there intrauterine substance exposure? And so that we're still kind of refining the definition of, because as we've seen, there are various drugs out there that can present a withdrawal symptom. We talked about opioids, benzodiazepines, other antidepressants, alcohol. And so we're continuing to refine that definition. But if an infant were to score a yes on that, then we ask them to check which of the following applied as far as how we were able to determine that information, whether it was a self-report, drug testing, or some other method. And then if they had said yes to the intrauterine substance exposure question, then whether or not they get diagnosed with NAS is a yes or no. And we have a standardized state definition, and of course we've talked about that with the group today. And right now, the standardized definition for our state is basically if an infant has intrauterine substance exposure and has any signs of symptoms of withdrawal, that would be consistent with a diagnosis of NAS. And so then they would click either yes or no. If you go to the next slide is just a close-up of what the actual birth score system looked like before we ended up revising it, which I'll get to here shortly. You can go to the next slide. So what the idea of the birth score is to really do is to serve as an intermediary between a birthing hospital and then transitions of care. And so you can see kind of this flow chart where you have a birthing hospitals that complete a birth score and then submit that report to the birth score office. And then we actually fax referrals to several places depending on qualifications. And so infants that get high birth scores, depending on their insurance, we either go to one of two places. And so those that get a high birth score, we either go to a home visitation program called Right from the Start, or there are other visitation programs that we do. And again, those are based on insurance. Or you can go to the birth to 3 route if you meet one of those 3 criteria that I had mentioned in the beginning. If you had a 5-minute outcar less than 3, if your birth weight was less than 1,500 grams, or you had a congenital anomaly. We also fax referrals to all pediatricians within the state. So whatever the general pediatrician that was identified on the birth score, they would also get a fax of an infant that would be high birth score, and it would list the reasons as to why they were high birth score, and then ultimately, hopefully, transition to improving healthcare outcomes, as you can see there. So if you could go to the next slide. One of the things that I did, or I noticed when I had took over as the director for Project Watch, was there really wasn't the clearest methodology that was in place as to how the initial weights to determined and whether or not there were other variables out there that could predict infant mortality. And so if you go to the next slide, we actually underwent a rigorous year or two of trying to update the score, looking at other various maternal factors or infant factors that could play a role. And if you can look at the left of the screen, you can see what I have the current birth score. And so that was the one that Dr. Mullet, I had mentioned before, had created. And then the one on the right is the one that we have actually revised and have published. And you can see that we've expanded it now to include 10 risk factors there, and the scoring weighting has changed dramatically. If you go to the next slide, you can see the other things that we have tried to do with the birth score. So on the initial birth score, there was this congenital anomalies or abnormalities tool or part. And there are a lot of things there that we tried to really consolidate into more a system-based approach. And so to make it a little bit easier, since some abnormalities, for instance, like Down syndrome can encompass significant amounts of abnormalities in various systems. And so we felt that was a little bit more appropriate to do. If you go to the next slide. So this just talks about, in essence, what, in revising it, what things that we've run into. And I think that the biggest strength for us is we really went through a robust statistical analysis of the birth score that we use now. And we've shown that it really has great predictive capability for infant mortality. And again, we've also been able to include other things as we've evolved the tool to add more surveillance items such as NAS. Of course, one of our biggest things is because in West Virginia, our birth numbers are relatively less than several other states. And so that can be a little bit problematic when trying to use such a tool in other states. So if we go to the next slide, and I'm going to kind of finish up here, what we're able to understand is that with the updated score, we were able to better predict infant mortality. And then we felt that this was much more clinically relevant for pediatricians as a result of being a better predictor. And then really working hard to arrange for closer follow-ups, which really could be its own talk in itself. So next slide. And just to finish up, one of the things that we've really wanted to do with the birth score tool is to look at other potential outcomes. And so one of the biggest ones that I've had an interest in as a general pediatrician is looking at more morbidity related stuff. And that's where NAS and those types of things would potentially fit in. When we look at things such as developmental delay, one of the things that we're really starting to focus on and see are a lot of the NAS babies, what happens to them after they get older and get to school with the behavioral stuff that you tend to hear about. And so those are some things that we're hopefully being able to pursue. And then we would love to be able to look at the scoring system in other populations outside of West Virginia. And you can go to the next slide, and that's it. So I thank you.
Great, thank you so much, Dr. John, and thank you to all our presenters. In the interest of time, we'll capture all the questions that came through in the chat and follow up with the presenters and send out questions in the follow-up email that you all will receive shortly. So thank you again to everybody for joining the call today. It was a wonderful discussion, and before we discuss next steps, please just take a moment to answer the poll question displayed on your screen. So we will be releasing the application for the 5 field placement opportunities in the coming week. After release, we will be hosting an informational call to provide additional details and answer any questions. Please be on the lookout from the omni@asco.org email account with that information. As a reminder, please send back your state action plan with progress updates and any current TA requests to ASCO by Tuesday, April 16th. And finally, ASCO would like to encourage states to incorporate your state or regional primary care association on your teams. We've included a letter in the calendar hold outlining some of the benefits. please contact either OMNI at ASTO.org or Ellen Pliska at epliska@asto.org if you have questions or like help connecting with your state's primary care association. As a reminder, please complete the evaluation that was just put into the chat box. Your feedback will help us for the next ASTO Connect in June 2019. Thank you again for your participation in our OMNI Learning Community ASTO Connect today. We hope you have a great rest of your day. Thank you all so much.